Okay, we talked about the treatment of these injuries during the first part of the lecture. Really quick, just going to do it by the slideshow. Avulsion, replace that avulsed flat back to its original position for that circulation. Um, if it's completely separated, you want to wrap that in a sterile gauze and take it to the emergency room with you. Sometimes they'll try to reattach that stuff. Amputation. If an amputation involves a large area of muscle mass, apply a tourniquet because they're going to bleed, and treat the patient for hypovolemic shock. You want to take that amputated part, wrap it in dry sterile dressing, put it in a plastic bag, and keep that bad boy on ice. With partial amputations, you want to make sure you splint that. Big thing is anytime you splint, you want to splint in the position of function. And I have seen people turn around and splint that joker back in place and the patient be able to move their hand because their nerve endings were intact. So, that's a very good chance that that limb is going to be able to be reconnected and fixed. Um, so you want to immobilize that part with some soft, bulky dressing, splint it to keep further injury, and rapidly transport them to a hospital, preferably a hospital that could reattach that part if needed. Um, Animal bites, scene safety. Don't enter if a dog's going to bite you. Make sure the animal's secure. Make sure they're gone. Control the bleeding. Put a dry, sterile dressing on that bite. Immobilize, splint that area up. Take them to the hospital. They're going to need some deep cleaning, some surgical cleansing, and they may need some antibiotic therapy and possibly their tetanus shot. Penetrating wounds, remember, under the penetration is where the injury is. With gunshots and things, you want to make sure you check for entrance and exit wounds. This says that they're difficult to distinguish, and sometimes they are. But if you're dealing with a gunshot, the entrance wound is typically smaller than the exit wound because of that cavitation. We usually have that pressure wave blowout on the exit wound. Now, your low velocities, you may not be able to tell the difference in an entrance and an exit, but you want to know, what got them. You want to kind of get in your mind that direction of travel because that'll tell you what organs could potentially be injured. Make sure you find all the wounds and control all the bleeding. Worst thing you can do is get tunnel vision and focus on one area and not do your assessment. That's why you're taught a systematic assessment. So as you're doing your assessment, you're finding these injuries and fixing them. The damage from a gunshot wound is directly related to the size, shape, and speed of the bullet. Larger calibers, your deer rifles that have the big fast bullets are going to cause way more damage than your smaller caliber handguns. Okay, and the big thing with these is cavitation. Okay, this didn't talk about it, but with abdominal wounds, you want to put a moist, sterile dressing over it and then cover it with a piece of plastic to make that an occlusive dressing. We talked about impaled objects. If the object is long, cut it off. We're not pulling objects out of people. We'll cut the object to where we can fit it in the ambulance and take care of the patient. And you want to secure it to minimize motion so it doesn't cause any additional internal damage. Your neck wounds, as you can see. All right, so now we're going to start talking about burns. And what a burn is when part of your body is exposed to some type of heat or energy or radiation or chemicals that harm the skin. Okay. Um, Once you get to a certain amount of heat or radiation or chemicals, then your skin begins to break down. And that breakdown is what leads to injuries from burns. Uh, these injuries can be systemic. You think about some chemicals. As they burn the skin, they also absorb through it. You think about a lightning strike that will have an entrance wound in, say, a shoulder and an exit wound in the feet. And everything from that entrance wound to that exit wound has been burned internally. What happens is these burns damage the cells, and the cells release different chemicals like potassium, sodium, those kind of things begin to leak and come out of the cell, and then you start having fluid shift. And what fluid shift is where plasma actually leaves the vascular bed and rushes over to the tissue, over to the area that's burned. And when you look at these burned areas, you start seeing the redness and the swelling. That's the inflammation and that fluid shift. And a lot of times you'll actually have where the burns are weeping plasma out of them. I've had patients burnt so bad in the back of the ambulance that their plasma from where it weeped out of the burns would literally was dripping off the end of the stretcher. So we can see some really bad burns from these chemicals and this plasma that's released when the skin is damaged. And this is how you get hypovolemia. Uh, the plasma, as it comes out of the blood, reduces blood volume, and this blood volume then results in hypotension. It's almost like a form of, well, it is a form of shock. Your blood pressure drops and you can't perfuse your cells. Um, as the burn destroys the skin, when you're talking third degree burns or those really, really deep burns, you get a leathery look. And that leathery look is it looks almost like charcoal or something on your skin. It's a dark black color. You can also see a real waxy white color. So if you see pure black dark or that white waxy color, those are third degree burns. And a lot of times that swelling, if it starts to compromise circulation, we'll need what's called an escharotomy, and that's where they go in and cut the skin to relieve the pressure off of the area of the body. We see this a lot of times when like people with real bad chest burns are having trouble breathing. They will actually cut like a big X on their chest or cut them over on their side so as that skin can stretch and expand and that patient will be able to take a breath. With your extremity burns to your arms and to your legs, if you have like a circumferential burn or a burn that goes all the way around that leg, you may have to do an escharotomy and cut that skin so it'll stretch and expand, and you'll be able to get some circulation and some perfusion to that area of the body. So hypovolemic shock occurs with the loss of plasma through those burns. Okay, and what happens is when you get burned, you have the loss of plasma or even blood, depending on the burn, through the skin, and then you have that massive fluid shift from the vascular bed into the area that was burned, and that will cause severe hypovolemia. Um, Depending on the nature of the burn, coagulation disorders may occur, and we see this a lot of times with your chemical burns, and lightning strikes as well from the internal damage of the electricity. But we really see it with chemical burns where it's absorbed into the skin and it changes the composition of blood. It'll actually liquefy the skin, and those can cause blood clots and clotting disorders within the patient. So that's something that we have to keep in mind. And also, a lot of chemicals will cause almost like a hemophilia type state where the blood will not clot. So you may have DIC or diffuse clotting all over the body, which causes strokes, heart attacks, multi-organ system dysfunction. Or you may see the body's inability to clot depending on what the burn affected and what was involved in the burn. And so you may have massive bleeding, patient bleed to death just from whatever they were exposed to. So burns, high risk of infection, because remember, we wipe that covering away and open up the inside to the outside, so we're really concerned about infection. One of the things that we can control in EMS is hypothermia. That's why we wrap our burns in dry, sterile dressings, not moist dressings, because we want to make sure that we're preserving body heat and not causing hypothermia. And just a word to the wise, if your patient's shivering, that means that they are hypothermic. And then you have hypovolemia, and we'll talk about how to prevent hypovolemia with IV fluids. Burning, especially if you see soot around the nose, that black charry stuff around the nose, the mouth, singed facial hairs, hoarse speech or difficulty breathing. Then we really start to think airway obstruction. Did we burn our glottis or our epiglottis, and is it swelling? Is it closing shut? And is our breathing compromised? Do we have chest burns that's causing pressure on the chest? Do we have an inhalation injury where we got smoke or soot in the lungs? Is our breathing compromised? And do we have compartment syndrome? Because that fluid shift is going to cause swelling, and that swelling is going to decrease circulation. So we really have to think about compartment syndrome in our burn patients. Now, your burn zone, it almost looks like a target. And what that looks like is right in the middle of this target, right where that burn is, that's called the zone of coagulation. So that's where the heat was. That's the part of the body that's burned, okay? And then around that zone of coagulation, you have the zone of stasis, okay? And the zone of stasis is where that heat spread out and damaged the blood vessels and damaged the tissue. So you're going to have like some coagulation, some blood clotting there. You'll see some skin color changes. And then the zone of hyperemia is this area out here. And this area is still affected. It's just not affected as bad. So there may be some heat-related injuries. And if you kind of want to think of a third-degree burn, you'd think that would be third. Outside of the third degree, you'd have some second-degree residual burns from the heat. And then out here, you might have some first-degree burns. But the zone of coagulation is where the most heat was. And the zone of stasis is the injury around that area that's caused from that heat. And the zone of hyperemia is the areas around that. It's the least affected area, but it still has some effects. Okay, so we gauge burns on how deep they are. The deeper the burn, the greater the degree. We use the superficial, partial thickness, or full thickness, or the first, second, and third degree burn. You may see it referred to either way. Just know that a first degree burn and a superficial burn are the same thing. That is a painful red burn with no blistering, like a sunburn. Partial thickness burns are your second degree burns. Those burns have blisters and they're very painful, just like first degree. The full thickness burns are the third and fourth degree, if you want to kind of stick that in your mind. Those burns typically don't hurt. They're so deep that they have burnt all the way through the dermis. What you have is superficial burn, that's your epidermis. Partial thickness burn, that's your dermis. Full thickness is when you've burnt through the epidermis, the dermis, and now you're into the subcutaneous layer. And they even add that third degree is subcutaneous layer. Fourth degree is where you have burnt through the muscle all the way down to the bone. I don't know that you'll be responsible for knowing those other classifications, but I stick them in the back of my mind because you never know what National Registry is going to throw at you. So superficial, that's your first degree, that's your epidermis. Partial thickness, that's your second degree, that's your dermis. Full thickness, that's your third and fourth degree, that's your subcutaneous muscle all the way down to the bone. The depth of a particular burn is hard to accurately estimate, but what we say is redness without blisters, painful, is going to be your superficial burn. Partial thickness is your redness, painful with blisters. Your full thickness is that black, charred, or that white, waxy looking color. And these are usually have the least pain. And here's some pictures. This is your standard first degree burn. Okay, see the tan line. Okay, those are typically not life threatening. Handled at the house with some aloe, life is good. These are your second degree burns. Okay, you see the redness and the blistering, and this would be your third degree burn here. That white right there, that white waxy looking or that dark charred color. And here, if you look really close, you might could find some third degree burns in there. And this is just kind of a picture of what it looks like. First degree burning basically stops at the epidermis. Second degree, you've got damage into the dermis, kind of stops right there. And then third degree, we're off the picture. We're way down into the muscle, the fat, and those layers. So that's kind of the different depths of your burns. So 5 factors determine the severity of the burn. How deep is the burn? Where is it at? What area? Burns to the hand, feet, joints, face, and genital area are automatically considered critical burns. How bad is it? A second degree burn at say like 30% of the body would be considered critical. A third degree burn of really any size would be considered critical. And then there's the other factors. It goes just a little bit beyond the burn. Is the patient a diabetic? Do they have horrible medical conditions that's just going to screw up their recovery? And are they young? Are they really old? Or how are we going to heal from this burn? What medical conditions affect the healing process? And then is there underlying trauma? A burn patient, number one, we take care of trauma. Number two, we take care of the burn. So we want to get the trauma fixed first, and then we'll worry about the burn. But that trauma is going to affect the healing process and slow that down, and it's going to make the burn that much worse. Okay. We measure burns by the rule of nines. Now, the rule of palms is more accurate, but we typically only use the rule of palms for funny looking burns that aren't continuous, where we would have splotches of burns over the patient's body. And we also use the rule of palms for irregular burns or small burns. Now, the rule of palms is that the palm of the hand, not the fingers, not the wrist, but the palm of the hand equals 1% of body surface area. Okay? And now the rule of nines says that every section of the body, or the 11 sections of the body, is worth about 9%. So the head is worth 9, the trunk, front side, is worth 18, with the chest being 9, and then the abdomen being 9. Okay? Each arm is worth 9. Okay? The whole arm, front and back. The back is worth 18, and each leg is worth 18. So 9 on the front, 9 on the back. The whole arm is 9, so it would be 4.5 on the front, 4.5 on the back. The chest is 9, abdomen is 9, head is 9, and the back is 18. So the back could be divided into the lower and upper back for 9%. So here's a picture. Back is worth 18, head is worth 9, the chest is worth 9, abdomen is worth 9 for 18. The whole arm, front and back, is worth 9. So the front of the arm would be 4.5, the back of the arm would be 4.5. Each leg is worth 18. Front of the leg is 9, back of the leg is 9. Genital area is 1%. Now for kids got them big old heads. Okay? So what we did with kids is we took from the legs and we added it to the head. Okay? So toddler on up, bigger kids, their head is worth 12% and their legs are worth 16.5. Okay? Everything else is the same. In babies, the head is worth 18% and the legs are worth 13.5. Okay? You're just going to have to memorize those. You have to memorize those rules of nines, because you will get questions on National Registry and on your unit test that just straight up ask you, what body surface area is burned, and it outlines those burns for you. Okay, so assessment of burns. We want to look at everything the same way we do with everybody. BSI PPE, is my scene safe? What burned them? If it's an explosion, you don't want to go bebopping in there and get yourself exposed to whatever. Are we dealing with a chemical here? Which way is the wind blowing? Are we dealing with fire, smoke? What are the hazards? Do we have the potential for spinal cord injuries? Do we need C-spine? Which is going to make managing that burn a lot different and a lot harder, especially when we start talking about airway management. Are we going to have C-spine while we're managing that airway? So consider your C-spine. That's going to really tell you, kind of what's going on with your patient. Look at your mechanism of injury, those kind of things. Do a full body scan. Do you see any major bleeding? Level of consciousness, airway, breathing, circulation. Pay specific attention to your airway. Do you have wheezing? Do you have stridor? Do you have those things that are indicating that you're going to need aggressive, advanced airway management quick? Assess your pulses, look at your perfusion, and those kind of things, because you really want to know if your patient's in the middle of fluid shift, or they may have some kind of underlying injury that you're just not picking up on. So you want to make sure that you're assessing all of those things, your circulation, your airway, making sure your ABCs are took care of. And then you want to move to your DCAP BTLS assessment. Remember, DCAP BTLS stands for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. So you want to make sure you're checking the entire body for those burns. Find out what the chief complaint is. Sometimes the chief complaint isn't really the burn, is something else. Like we've had diabetic patients who have had issues with their burns, and that not be the real reason. They got burned because they were a diabetic and could not feel the heat being applied to the back of their leg. So we want to make sure that we're checking all that out and really looking into their history. Get your sample history, find out what's going on, find out where they were burned, how bad they're burned, what they were burned by. That way you can start judging and addressing your treatment. Get your sample history, ask your questions. Just go through the motions and follow your assessment sheets. Do your detailed physical exam, do your DCAP BTLS, do your rule of nines, get your rough estimate. That matters because you're going to do fluid replacement if you're an advanced EMT based on that rule of nines. What's the classification of the burn? First, second, third degree. Is it bad? Is it critical? Look for soot around the mouth and nose, singed nasal hairs, singed facial hairs. That screams airway burn. Listen to breath sounds. Do you hear stridor? Do you hear rails? Do we have fluid? Do we have swelling? Get the patient's neurological baseline. Do your Glasgow Coma score. That way you can start trending and see what else is going on with the patient. Full body exam. Assess the musculoskeletal system. Look for broke bones, any injuries that could have occurred from the burn. Get you an early set of vital signs because trending is going to become really important. That's going to kind of let you know how your patient's doing. And use your monitoring devices to get oxygenation and circulatory status. Issue with the pulse ox. If your patient has carbon monoxide poisoning, their pulse ox is going to read falsely high. Carbon monoxide loves hemoglobin, so it kicks the oxygen off, and the pulse ox reads that because that is saturated hemoglobin. It's just not saturated with oxygen. Reassess these patients every 5 minutes. Pay attention to the swelling of the burn. Watch your vital signs. Watch your interventions. Okay. If you wrap a burn, it may swell and cut off circulation, so you may need to loosen that dressing. And let the hospital know what you're coming in with. Give them a heads up. Let them know percentage of body surface area burned, where the patient's burned, what they were burned with, what your treatment has been, and those kind of things. If special areas are involved, they should be mentioned and documented. So if it's a chest or a genital burn, that's very, very, very important. So what are we going to do? Step number 1, treat the trauma. Stop the bleeding, treat any major life-threatening traumatic injuries. Okay? You have to stop the burning process. If it's chemical, you want to flush the area with water. If it's dry powder, you want to brush that powder off and then flush with water. Stop the burning process. Cool that burn quick without causing hypothermia. Treat breathing. Treat circulation. Rapidly transport them to the hospital. Cover the burn with a dry, sterile dressing. Okay? That's your initial BLS treatment. ALS treatment involves aggressive fluid resuscitation. We need to keep those kidneys functioning and putting out urine, and we need to keep those blood vessels and that blood tank full. Okay? You will have to give IV fluids. This says consult medical control. The standard practice is using the Parkland formula, and we'll review that in a little bit. So thermal burns, this is a flame burn, heat burn. steam burn. Most common thermal burn I see is ramen noodles on kids. Take them out the microwave and they spill them all down their chest. Okay. Um, Flash burns come from explosions. Worked a peanut plant fire. They were pulling the peanuts out of the chute. The peanut dust caught on fire and engulfed 3 people really fast. They had burns over most of their body. Most of it was not that bad because of the duration of exposure, but they were severely burnt from that dust coming out. Um, you know, watch yourself on the grill. Put too much lighter fluid, throw a match, it will flare up and flash up into your face. And then you have lightning strikes. If you're close to the lightning, it'll cause a flash thermal burn, not necessarily an electrical burn. Inhalation burns are from hot gases or even sometimes hot liquids, but we really focus on those gases, that smoke that gets really superheated, that superheated steam. You inhale that, and it burns your upper airway all the way down into your alveoli. One of the main things we want to do is manage our airway quickly and aggressively and prevent infection. Okay, and inhalation burns happens a lot in enclosed spaces, or like somebody pops the hood on their car, radiator steam comes up and they gasp. That will cause a deep, deep pulmonary burn. We talked about carbon monoxide. It takes the place of oxygen on the hemoglobin, and it loves hemoglobin, so it kicks the oxygen off, sucks up and sticks itself to the hemoglobin. Pulse oximetry reading is going to read 100%, even though they're full of carbon monoxide. Treatment for carbon monoxide or any inhalation burn is high flow oxygen, 100% oxygen regardless of the pulse ox. And then you have hydrogen cyanide. And what cyanide does is it blocks the cell's ability to use oxygen. The antidote for cyanide is amyl nitrate, but cyanide is in smoke from like manufactured objects, carpets, couches, those kind of things. You get the cyanide from that. And then you have your chemical burns. These are for cleaners, anhydrous ammonia, fertilizers, those kind of things. That's an eye burn. That's a pretty severe eye burn. Homeboy gonna be blind for the rest of his life. But the toxic substance gets on the skin. You want to know what chemical, how long it was on the skin, and what they did before you got there. Liquid chemicals we flush with copious amounts of water, lots and lots of water for 15 to 20 minutes. Your powder, we brush those off and then flush with water for 15 to 20 minutes. The severity of the chemical burn is related to the pH of the fluid. The further away from 7.35, 7.5 being neutral, the further away from that 7.5 range you get, the more the burn's going to be. So, if you're up around 8 or 9, you're going to liquefy your skin. If you're down around 1 or 2, you're going to burn the skin, slam off your body. So be familiar with your pH scale and just know the further away from that pH scale you are, the worse that burn's going to be. How long were you exposed? How much of the agent was put on you? And then a lot of times on those treatments like hydrofluorocarbons, the treatment is actually calcium, but you're not going to go in that depth in that class. You go to paramedic school, critical care school, you will learn the actual specific antidotes for many, many chemical burns. Step 1, stop the burning process, remove the chemical. Okay. Water does really well. Flush them, brush any dry powders off, stop the burning process. With dry lime, lots and lots of water. With sodium metals, you cover them with oil. With hydrofluoric burns, you're going to use calcium gluconate gel. You actually take that and you mix that up in some KY jelly is how you make it. Gasoline, soap and water, hot tar, cold water. Okay, those are the ones your book wants you to be familiar with. There's several others that we talk about that we're not going to get in here. Eyes, saline, okay, or sterile water. You want to flush the eyes for at least 20 minutes. If you don't have saline or sterile water, use a water hose. Okay, you want to flush those eyes for 15 to 20 minutes, and if you'll notice where that cannula is, that is in the inside corner of the eye, and you're going to flush outward. Okay, if you need to flush both eyes, you can take a nasal cannula and put it upside down and run your IV fluid through that nasal cannula, and it'll flush both eyes at the same time. They also have a thing called a Morgan's lens that your paramedics can use to flush the eyes. Electrical burns, The big thing with electrical burns is you have an entrance wound and an exit wound. Depending on where you were struck at, that may be an entrance, that might be your exit wound. And what happens is that electricity travels through the body until it reaches those specific wounds. Okay, so you're going to need to treat the wound from the entrance, the wound from the exit, and you're also going to need to keep in mind that there's injuries all in between that entrance and that exit wound where that burn was. And just here's a picture of the electrical, where it goes in, and then the electricity arcs and spreads out and burns all that area all the way through your body. So you need to be really concerned about those internal burns versus those external burns. Also, the electricity will change the cardiac rhythm. It'll cause rhythms like VFib and VTAC that you have to do aggressive advanced cardiac life support or even basic cardiac life support for. And you would actually work these cardiac arrests for longer than you would with just a normal burn or a normal trauma patient, because the problem is not an injury or the burn, it's the electrical disruption of the heart. And you also want to check out and look for hypoperfusion. Make sure we don't have that fluid shift going on. Radiation burns happens from severe radiation. Alpha you can block with a piece of paper. Beta you can block with a shirt or clothing. Gamma, that's what burns you. Gamma is strong enough to cut through the skin. You've heard of gamma knife surgery. That is radiation. It literally burns through the skin. You can inhale this radiation, ingest it, or it can be direct exposure and absorbed through your skin. Radiation burns are deadly. Radiation sickness causes premature aging and death. They require special rescue techniques. Don't go running up in there taking nobody out of a radiological hot zone. Okay, that's the hazmat's job. Get your IV access, start your fluids based on your patient presentation, and really treat those patients. I'm going to throw this in here because this is it's a EMT lecture, but it's using advanced curriculum. The Parkland burn formula is 4 milliliters of lactated ringers per kilogram of body weight times body surface area burn. Okay, and so we're going to take 4 milliliters times their weight times the body surface area burn. Okay, and you'll get some ungodly number like 10 or 12,000 milliliters. First 8 hours they get half. Okay, the next 16 hours they get the second half. Okay, so that's the Parkland burn formula. We'll talk more about that when we get to IVs and fluid replacement. Just wanted to kind of lay that foundation and put that in the back of your head.